Good afternoon. Um, Today we're going to talk about the surgical treatment for hyperacusis. We've been doing this for 15 years now. First surgery was in 2010. And we moved into our building, let's see, in 2003, a 30,000-foot building. We have now like 16 doctors, many PAs, and many support help. I have no financial relationships to discuss. And I want to talk about the 4 types of sound hypersensitivity. Hyperacusis is what we're going to be talking mostly about today, but there's several other types that we have to differentiate from. Recruitment is another type, and I'll discuss that shortly. Misophonia and phonophobia. I want to push the button here. So, which button could I just push?
Just with the mouse clicker.
So hyperacusis is a condition where a person can't tolerate normal sounds. They become very anxious and they avoid places like movies, restaurants, and sporting events. And it often affects the quality of life. Many times they don't want to be with other people. They don't want to converse, and they stay in their room much of the time. It's said that 6 to 17% of the population is affected. These patients usually have normal hearing, but they could also have a sensory or a nerve loss. Their uncomfortable loudness level, or LDL, is below 90 dBs. The normal is between 90 and 100. Most people can tolerate that without much difficulty. Tinnitus is associated with many of these patients in about 40%. The treatment before surgery was earplugs, tinnitus retraining therapy, cognitive therapy, and long-term treatment was needed. The results were variable and were many times not effective. So recruitment is a sudden marked increase in sound that occurs when noise level reaches the patient's hearing loss thresholds. This is mostly seen in patients with Meniere's disease who have a sensory neural loss in the ear. When the sound gets up to the amount of hearing loss that they have, they suddenly hear a tremendous increase in volume of sound. And the treatment is the same using TRT and the earplugs. Misophonia is a reaction or an irritation to certain sounds, like dripping water or chewing or pencil tapping or chalk on the board. And phonophobia is fear of sound. And the LDLs, the uncomfortable loudness, is normal. And these patients usually need psychotherapy. Now, what causes hyperacusis is usually unknown, but many times the patients have a history of noise trauma in about 62%. There can be cochlear trauma, trauma to the inner ear, superior semicircular canal dehiscence can cause hyperacusis, which is a defect in the superior semicircular canal bone that occurs in certain people. Perilimb fistula or leakage of fluid can cause it. Adverse reaction to certain medications can cause it. And recently we found hypermobility of the stapes, maybe another finding. The possible mechanism is impaired neuroplasticity and noise suppression. Most of us can suppress noise in our brain when we hear loud noise. Hypersensitivity of the cochlea to sound is another possibility, and hypermobility of the stapes is another possibility. So our hypothesis was that the hypermobility of the stapes or hypersensitivity of the cochlea to sound could be reduced by placing tissue against a round and oval window, which would reduce the sound vibrations going into the inner ear and reduce the patient's symptoms. When we first started doing this, there were really no papers or anybody doing any of this. There was one person with hyperacusis that had a superior canal dehiscence, and they had the surgery with the closure of the round window with relief of the symptoms, but there was nothing else in the literature talking about this. So we operated the first patient in 2010, and it was an experimental procedure. The patient knew that and accepted that. And the patient came in complaining of explosion that happened when they were working. And they developed intolerance to sound on the left and a perforated eardrum on the right. So we talked to the patient and said, well, maybe if we put some tissue into your ear below the eardrum that would block the sound waves, maybe your symptoms would be less. And we did this, and the patient was cured of their problem, and they were very happy, and they've been happy up until present time. Here you can see the temporalis fascia that's placed in the middle ear, and we're going to show you more of this shortly. The second patient came in 4 years later, complaining of hyperacusis. And she said that she didn't have any noise trauma that caused this. She didn't know what caused it. And that impacted the quality of her life. And she would not go into any noisy situations. And we operated the right ear, and she asked for the left ear to be done. And she's been very happy ever since. So we're going to talk a little bit about the surgery, how we do it. We take some tissue from over the muscle, which is temporalis fascia tissue above the ear, and we use a little dermatologic punch to make 2 and 4 millimeter pieces of tissue that we can place in the middle ear. This I'm going to show you several videos that will describe the procedure. You can see how this is done. So this patient had a hypermobile stapes, so you can see how loose everything was when I was touching it with the instrument. The chorda tympani nerve, the nerve of taste, is running across the picture. And we used electrical stimulation to see the contraction of the stapedius tendon, which is right here. And you can see that moving very violently. After we put the tissue around the stapes and the oval window and the round window, you can see how much less movement there is of the stapes and the incus. And when we do electrical stimulation, you'll see that there's much less movement. So you can see that again, this is hardly moving at all. Okay. Here's another video. It's not running. Okay. Here it goes. Now this talks about an improvement in the surgery by adding extra tissue. You'll see. which biopsy tool is used to make the 2mm and 4mm temporalis fascia grafts. For the round window, two 2mm pieces are used. Two pieces are used, and then a 4mm piece of temporalis fascia is placed over this. And held in place with a small piece of gel foam. Now the gel foam is being inserted. That's holding the temporalis fascia in place. Now 10 2mm pieces of temporalis fascia are placed around the stapes and on the foot plate to reinforce the oval window. The temporalis fascia are placed anterior to the crura and on the foot plate and beneath the stapedius tendon, and also placed on the foot plate. Takes about 30 minutes to do the procedure. Standard procedure that we do in every case. Doing this to decrease vibrations of sound going from the ear canal to the cochlea, try to reduce the hyperacusis that the patient has. Now we're putting a 4mm enhanced piece of tissue over the incus. This will act to enhance the oval window reinforcement. This is the new addition to our procedure by adding extra tissue to the middle ear and the eardrum. A 6mm piece of temporalis fascia is used to place beneath the posterior half of the tympanic membrane and part of the tympanomeatal flap. And this is the procedure. Okay. There's one more. Let's see. So to evaluate the effect of the round window and oval window reinforcement in reducing the symptoms, we did a research study, and we had 73 patients. We're up to 82 patients now that we've operated. We do a hearing test and a loudness discomfort level and a CT of the temporal bone to rule out that superior canal fistula. And they fill out a questionnaire, hyperacusis questionnaire, and they mark their severity between 1 and 10, 10 being most severe. And after surgery, they fill out a Glasgow benefit inventory survey. So after a medical intervention, we talk about their general health, their physical health, psychological health, and social support. So we did this, we measured this at 1 week, 4 weeks, and 52 weeks following surgery. Here you can see a picture showing the extra tissue down on the round window. Here's tissue being placed around the stapes, as in the video I just showed. So we divided the patients into two groups, and we divided them up depending upon their loudness discomfort level. Those that had moderate discomfort, that is between 70 and 90, there were about 52 patients, and 21 patients were in the severe group. They had high discomfort to sound. They were below 70. So in the post-op improvement in the moderate group, 80% or 81% would recommend the surgery and were satisfied with the result. And they stated that the improvement lasted for a long period of time, from 1 to 6 years. In the group that had high discomfort, only 50%, 47% would recommend the surgery. That's when we decided to start adding extra tissue and develop the enhanced reinforcement of the round and oval window that you just saw. So this is a picture of the enhanced, putting the temporalis fascia in over the 10 pieces of temporalis fascia. And this is showing the eardrum that's been reinforced with the temporalis fascia beneath it. And this just shows you the pre-op LDL was 65 on this patient, and a week post-op after we took the packing out was 95. So the results of the reinforcement in 6 out of 7 patients, now we're up to 8 patients, have been very good. And the one patient that didn't receive a good result, their LDLs did improve quite a bit. And it must be, their problem must be central or problem in the brain that's not related to the movement of the ossicles. 3 patients stated that the surgery prevented them committing suicide. And the unoperated ear many times improves and may not need surgery. We're not sure why this happens, but this is what happens. Tinnitus was not changed in any of the patients. So in conclusion, the loudness discomfort level is a good predictor of the possible success of the round and oval window reinforcement surgery. And those with the pre-op LDLs of 70 dB or greater have an 81% chance of improvement, while those with the LDLs below 70 dB have less of a chance and have about 47% chance of improvement. So with putting the extra tissue in and creating the enhanced reinforcement of the round and oval window, more patients are going to do better. And I think this is the procedure that we're going to continue doing on all the patients from now on. Thank you. So I'll take some questions if you want to ask.
Show them the video.
Do you have it?
You can pull it up and share it.
We have one more video to show you of the hypermobility. Well, we don't have to see that really.
There.
We could, all right, you're bringing it up now, or you don't have to be dizzy. That's
No, but that's just what it is.
no, that's not the one. All right, why don't we just take questions? Turn that off.
The first question is, I have strong hyperacusis, but also a hearing loss, mostly on my left ear. How is the risk of acquiring a hearing capacity reduction after the surgery?
Most of the patients have had their same hearing as they had before surgery. Sometimes there's a small conductive hearing loss temporarily due to all the tissue that we put in that improves over a few weeks to a month. But we really haven't had any real problems with that.
Question is, when will the new findings be released? And once they are, will other surgeons around the country be able to perform the updated surgery?
The paper is in press right now. It's been in there about a month. We're waiting to hear about when it's going to be published. And we have sent the video that you saw actually to many surgeons around the country. And we're going to have 7 or 8 of our fellows that we've trained doing the procedure around the country. And in a month, we're having a seminar here to teach other surgeons that want to do it how to do the procedure. We're going to have the seminar here on a Zoom conference.
The next question is, my husband has been diagnosed with extremely thin but intact but superior canal. Main symptom is hyperacusis with significant auditory distortion, reactive tinnitus, no significant vestibular symptoms. Would you recommend this surgery?
Yeah, I think so. I think it would work because actually, even if there was a fistula there, the surgery is very similar than doing this reinforcement. We wrote a paper on that, on reinforcing the round window for superior semicircular canal some years ago. So I'm pretty sure this would help the patient.
Sound injury.
Go ahead.
Sound injury, constant ear pain and silence, stabbing and burning with setbacks after hearing sound. Will this surgery help me?
I think you need to have a hearing test, an LDL test, and an X-ray of the temporal bones, and evaluation, and then we could tell you whether it would work.
How long does a patient have to have hyperacusis before you will perform the surgery?
We usually like to wait 6 months and have the patients try conventional therapy with TRT, wearing earplugs and sound therapy before doing the surgery.
Why do some people's tinnitus and hyperacusis get worse after surgery?
That's a good question. Not sure.
What are the requirements for getting this surgery?
Having an evaluation, consultation that we can do by telemedicine, and observing a hearing test, an LDL test, and a temporal bone X-ray.
I have both hyperacusis and tinnitus. Is the tympanic membrane that will flutter sometimes? Is it the tympanic membrane that will flutter sometimes?
Well, the tympanic membrane will be quieted down by putting the extra fascia in, so that may be helpful. But the procedure does not help tinnitus per se.
If the patient is unable to travel to Sarasota, is it possible to obtain the list of the 7 or 8 fellows who are already trained around the country?
Sure. Yes, very easy. We can, let us know who you are, we'll send them to you. Sure.
And we could also send them with the recording.
Yeah, we can send there.
Have you had any patients complain of a distortion to S sounds, that S sounds are sharp and unbearable? Have any patients specifically reported this symptom to get better?
No.
Having trouble reaching the office for appointments.
Oh, good luck.
So we can
You can do it through the Ear Research Foundation.
they can just send us an email.
If you send an email to the Ear Research Foundation, we can set up a consult through the Foundation. The hospital's now allowing us to do that since they're so busy. And we can do the consultation, and if you need the surgery, then we refer you to the hospital, and then we do the procedure there.
And I can add all that information when we send out the recording.
Yeah, we can send the recording and all that information, how you can sign up for a consultation.
Okay, the next question is, are there surgeons in Europe, Switzerland, or would it be necessary to come to Florida for surgery?
Well, we've had patients come from 4 countries, and I don't see why a surgeon in Europe or anywhere couldn't do this procedure. They were interested in doing it.
Is there any way to do the surgery so it can become reversible if someone wanted it reversed, like using Teflon or something similar?
We have not had any patient ask for us to take out the tissue, but we've gone in on one patient that had it 4 years before, and the tissue grows to the little bones of hearing, and would be almost impossible to take out. If it was taken out soon after the surgery, if the patient wanted it out soon after the surgery, it could be removed. But we haven't had any patient, and we've done maybe 100 cases now, 100 surgeries on about 82 patients. And we haven't had one patient ask for that.
Okay, the next question is, how is it determined if a patient has hyperacusis from CNS?
From what?
CNS. Maybe they need to,
I don't understand that question.
let me go to the next one and I'll ask. Would this one layer added to the eardrum be a patch lasting a lifetime?
Yes.
Okay, and then back to that question is, how is it determined if a patient has hyperacusis from central nervous system?
Oh, good question. So if they don't respond to the surgery, then the problem obviously is a central problem. And the only way of knowing that, the way I to this point, is to do the procedure. So if it doesn't work, it doesn't work, and then the patient will have to deal with the problem without surgery.
Okay, the next question is, if it grows once it is in there, is there any concern that it would grow in a way that could be a problem?
No. No, we've done many cases of reconstruction of the middle ear with fascia for damage due to infections and cysts that destroy the little bones of hearing. And we've been doing this for many years and never seen any problems from it.
Would there be any benefit, do you think, from getting only the eardrum patching?
Some people have said that, and I've done it myself, to put a paper patch on the eardrum to see if that helps. I don't know. I think that when you're doing research and you're doing procedures, you need to do the same procedure exactly the way you do it every time on every patient, and then evaluate the results after you do a whole series of patients. And that's what we've been doing for the last 15 years. So right now we're using the enhanced technique. And after we do 20 or 30 patients, we'll evaluate what the results are. But so far, it looks like this is going to be the best treatment, the best surgery for it. And I think that's the only way you can do it. Is so if you start, that's one of the problems with the patients having the surgery in different areas and by different surgeons, and why we've resisted that up till now, is because we don't want people changing the way they do it and make a different surgery, and then they'll say it doesn't work. This way, it's all done the same way every time by the same surgeon, and we can evaluate the results that way. So I don't think it's a good idea to do a half job, like just patching the eardrum.
Next question is, what are the risks of the procedure?
The risks are hearing loss. Whenever you operate on the ear, there's a slight chance of hearing loss from the surgery. The chordotympany nerve, which is the nerve of taste, could be stretched, and you'd have a taste disturbance for some months after. We haven't seen this on any of our cases. Infection post-operatively, which we haven't seen. We give patients preoperative antibiotics. So, and the fourth is that it doesn't work. I don't know whether that's a complication, but that's another possibility.
The next one is, the patient was diagnosed with it being a central nervous system. Would they still be able to get the surgery if they wanted to?
Yes, because I don't know how you would know that. I think we need to have a consultation and evaluation. We can tell pretty much by talking to the patient and getting their history and whether we think they're going to be a good surgical candidate or not. Patients with a lot of problems, other than the hyperacusis, don't do well. In other words, if you have hyperacusis, tinnitus, imbalance, vertigo, other problems in your body, other diseases, it's not good to just operate for the hyperacusis because it may not really help the patient much.
The next question is, could you do the surgery with Teflon if someone paid extra just in case they wanted it reversed, or it's not something you would do?
No, I just explained to you that we do everything the same every time, and then we evaluate the results. We can't be changing and doing different things. That's the way research goes. I mean, you'll never know what you're doing if you change the procedure every time.
The next question is the training that you are having next month for surgeons an in-person only event, or can international surgeons attend?
International surgeons can attend. We're going to send out
Information
to everybody.
Are there any precautions required after the surgery?
Well, we like to keep the ear from being wet, and there's some packing in the ear after surgery. There's very little pain. There's really very little post-operative care.
Do you know why the second ear often resolves, or it's uncertain?
That's a great question, and one that's been very difficult for us to figure out, but we think that it must be a central. What happens is that when you reduce the sound vibrations going into one ear, centrally, it must affect the other ear too. So because there are cross paths in the brainstem, so it's possible that the second ear can be improved by the first ear.
Can the patient fly after the surgery?
Yes, we let them fly a week after surgery, as we take packing out of their ear, and we let them fly if there's any cold or they have allergies and whatnot. We have them take a decongestant and Afrin nasal spray to make sure that their eustachian tube opens when they land.
The next question is the upcoming paper with the results of the enhanced reinforcement. How many patients does it include? Are any of them with severe hyperacusis, less than 70 dB?
Yes, many of them were severe cases. And I think there's 7 cases that we reported.
Is the new eardrum patching procedure essentially the same procedure as myrincoplasty?
Laryngoplasty, yes. Very similar. Okay, so if you want a consultation or if you want to get more information, we'll send you the information and you can set up an appointment with me, and we can do a consult through Zoom. And we just like to try to get the information, as much information as we can before the consultation.
Okay.
Okay.
Yep.
All right. Well, thanks everybody for coming. We'll talk to you later.
I had 2 questions. My LDL is probably at about 70. I've had it for 4 years. I've also had like vertigo off and on, but I haven't been diagnosed with Meniere's because I don't have any hearing loss. So I do when my flare up was original, I did have really bad fullness in the ears. Um, is that like, do you have some people that did not have Meniere's but had hyperacusis and fullness in the ears and the surgery helped them?
Yeah, so this is a little different. This is the recruitment that I was talking about.
Yeah.
If you have episodes of vertigo and pressure and fullness in the ear, it's probably due to increased pressure in the inner ear or Meniere's disease.
Mm-hmm.
In that case, what happens is the hyperacusis is really recruitment, and what happens is that when the sound gets to the level of the hearing loss, suddenly the whole inner ear is activated and you hear the sound very loud. But
Okay.
that's not going to be helped by the surgery. The surgery is only for patients with hyperacusis.
Okay.
And if the patient has a lot of other problems along with the hyperacusis, and hyperacusis is really not a major problem for them, then we would
Okay.
not do the surgery because it's not going to affect their quality of life if they have a lot of other problems along with
Yeah.
the hyperacusis.
I haven't had the vertigo for years. It's just the hyperacusis and tinnitus that I have now, that for the
Well,
4 years. So,
So
um,
you should have a hearing test
okay.
and an LDL. What is your LDL now?
If I had to guess, I'm going to say at around 70.
Right. So you would be a good candidate for the procedure then.
Okay. And my other question is, how do you secure the tissue in there? That's just a scientific curiosity.
How
Like,
did I missed that?
like when you put the tissue into, I'm not using the right medical term, but when you put the tissue into the ear, how does it
Right.
stay in place? I'm
Oh,
curious.
good question.
Yeah.
So what we do is we scratch the bone of the ear to make it bleed a little bit.
Okay.
And so we've had one patient recently that we did a revision on, and the tissue is still there. Was 3 or 4 years later. So
Okay.
the tissue does heal to the bone there, and it stays in place.
Okay. Thank you so much.
Right.
There's another question. How many layers are placed of the tissue?
Right. So in the original series, we just did 3 pieces of tissue on the round window with 1 little piece of tissue on the stapes. We did that for 2.5, 3 years until we found a patient with the hypermobile stapes. Then we started another series of patients putting 10 pieces of that 2 millimeter pieces around the stapes and 2 millimeter pieces on the round window with a 4 millimeter piece over that. And those cases were the ones that we reported here. And so we've done that for about 3 or 4 years. And then now we're doing this enhanced amount of tissue And so that after we put the 10 pieces in, we add another 4 millimeter piece over the incus and drape it like a tent over the incus bone, and also reinforce the eardrum with another piece of tissue. And that seems to work very well and give us the best results so far.
And the other question with that is the tissue in front or behind the eardrum?
We lift the eardrum up like a book. Actually, we lift the eardrum up and we're looking inside like you're looking inside a book. And you put the tissue inside behind the eardrum. So if you look at it, you could think of it as wearing an earplug inside your ear instead of the earplug on the outside. And because it's in there permanently, it stays there and it works better than just the earplugs. And we haven't had any patient ask to take it out, take out the tissue. If it doesn't work, it means that the problem is caused by a central problem, probably in your brain, and that surgery is not going to help reduce the hyperacusis. Unfortunately, it's not a lot of patients that are like that.
Okay, the next question is for patients that are in Europe. What do you suggest as far as doctors having this procedure?
That's a difficult one. We've had several patients come from Europe to have the surgery, and it's not difficult surgery, and we've written 5 papers in the literature on this, and the procedure is shown on the internet also. So an ear surgeon who is interested in this could do it in Europe, but they would have to be interested in doing this kind of surgery.
The next question is, what is the lowest dBl you would operate?
I think we would operate on, we've operated on them as low as 40 decibels. And I think the LDL test is not a very accurate test. And one day it may be 140, the next day it may be 60, depending upon how the patient feels and how they react to sound. So I think that we really don't use that as a criteria to operate or not operate. It's really on the patient's symptoms and how much it's bothering them.
Okay, the next question is, if I have hyperacusis and can feel vibration from a lawnmower or drums, would you think it's still hyperacusis that they have? If they can feel noise vibration?
I'm not sure about that. If they can, I haven't heard many patients complain of that with the hyperacusis, that they can hear the vibration. I have a lot of patients that complain of pain with the hyperacusis, and that seems to be helped by the surgery almost every time.
Okay, the next question is, you mentioned semicircular canal abscess being ruled out by CAT scan prior to surgery.
Right.
I have heard semicircular canal dehiscence as a cause for hyperacusis, but patients cannot get MRI due to pain from the loudness of the MRI.
Oh, well.
Do you rule this out or explore fix during your surgery?
They don't need to have an MRI. The CT scan will show the fistula, and you do the same procedure. You'd still put the oval, the round window reinforcement and the oval window reinforcement, even if they have a superior canal fistula.
Okay, the next question. I guess, how do you determine and know in advance prior to surgery if the hyperacusis comes from the brain?
Very difficult. The only way to tell that is to see if the patient has other symptoms that are going along with the hyperacusis. And if they have psychological problems and other problems, it may not be due to just the ear, and putting tissue in may not help the patient. But I don't think you can tell in most cases until you do the surgery.
And the next question is the date of the latest research paper on hyperacusis.
You would have that.
It's very recent. I just have to look up the exact date.
Yeah, it's. I think it was a few months.
It was in the beginning of this year.
Beginning of this year. Yeah, it's in the American Journal of Otolaryngology.
We also have it listed, the date and title on the website. And
It's on the website too, on our website.
So do you operate also on pain hyperacusis or only loudness hyperacusis?
No, pain hyperacusis is affected very well by the surgery. For some reason, and I don't understand why, the pain goes away, but almost in every case, the pain goes away after doing the surgery.
Okay, the next question is, can a person have recruitment and hyperacusis? I have hearing loss and low frequencies, but high frequencies are also very loud. This all comes from an MRI.
If you have a low frequency hearing loss, it's probably due to high drops or Meniere's disease, and that's what's causing the recruitment. And I think that it's probably recruitment rather than the hyperacusis. I haven't seen any patients that have had both together. It's either one or the other.
Are you able to see on an MRI the semicircular canal abscess?
The MRI, we use the CT scan to see the semicircular canal dehiscence. It can be seen on MRI, but we use that. And CT is much easier to get, and it shows it very nicely.
How many layers are placed on the new eardrum patching?
One layer of temporalis fascia is placed beneath the eardrum.
Is the surgery reversible if it didn't work for someone?
I'm not sure about that. It would be reversible if it was done, if it was reversed soon after the operation, but after the healing occurs months later, it would be difficult to get the tissue out because it grows to the bone and to the little bones of hearing.
So if somebody were to travel here for surgery from Europe, is there a time frame that they wouldn't be able to fly after surgery?
Yeah, they stay here a week. We've had patients come in from Europe and they stay here a week, about 10 days. They come here on a Wednesday, get operated Friday, and usually can leave the following Wednesday or Thursday.
Someone is asking about the use of, I'm probably saying this wrong, clomipramine drug for
Botox, is that?
Clomipramine?
I
CLOMIPRAMINE.
I don't know about that.
Clomipramine, it's a TCA. It's an antidepressant they use for the treatment of hyperacusis as a drug. It numbs the nerve.
Yeah, well, I'm not familiar with that, but recently from Europe, I got a letter that some doctors are injecting the tensor valli palatini muscle in the mouth with Botox, And they say they paralyze the tensor tympani muscle and tendon, and that helps the hyperacusis. And I don't understand that at all, because I would think that doing that by paralyzing the tendon that's holding the bones from vibrating, that if they weren't working, they would be worse hyperacusis. So I'm not sure about that, but somebody has written to me about that procedure.
Are there any other questions?
Has anybody reported that they can feel the tissue in their ear after?
No,
Oh, that's good.
no. No, we do tympanoplasties, repair eardrums and the little bones of hearing, and nobody ever complains of that.
If hyperacusis is a damage inside of your ear, like what is the theory as to what's happening inside the ear? Like,
Well,
I know there's is it the like your theory for this surgery is the stapes, right? Like,
there's
yeah.
I told you there was three possible mechanisms
Oh, right.
that
Okay.
the brain is not suppressing the sound waves
Mhm.
going into your ear, that the cochlea is hypersensitive to sound,
Mhm.
and that the stapes is moving too much. So there's
Okay.
several different ways that it could be occurring.
And one more question. In your opinion, I know this is a theory, but if you have pain hyperacusis, could it still be the brain? Or do you think that must be the ear if you feel pain?
That's a good question, but all I can tell you is that almost every patient that had pain did not have pain after the surgery.
Okay, that's great. Thank you.
The next question is, can the operation make the hyperacusis worse, and what are the risks of the operation?
Very good question. So the risk of operating on the ear is causing more hearing loss, having an infection in the ear post-op, and affecting the chorda tympani nerve, which is that nerve of taste that runs right across where we're operating. If the nerve is touched or stretched, there may be a taste disturbance for several months after the surgery. We haven't seen that happen in any of our cases. We did in the first, we had one case that had taste disturbance. The other possible complication that it doesn't work, that's not a complication, but that it doesn't help. And as far as making the hyperacusis worse, I haven't seen that. It either doesn't help or it helps.
The next question is, does the tissue last a lifetime?
I think it probably does. The one case that we revised and went in to put more tissue in, the original amount of tissue was there and had grown to the bones of hearing and the round window.
Would you do both ears at once?
No.
Or you have to do separate?
No, we never do two ears at once, for fear that something bad could happen to both ears. And also you want to see how the patient reacts to the surgery on one ear and get that ear as good as you can before you do the second ear, because you may even not have to do the second ear.
And then approximately how much are the surgery costs?
It's about $10,000. Insurance usually covers it, and most of the expenses for the hospital and the anesthesia.
Any other questions? Why would the second non-operated ear improve after the first?
You're asking questions that I don't understand or have an answer for. That's a good question, but we think that the fact that the sound waves going into the brain are reduced, that it affects the opposite ear also, that it acts to help decrease the sound coming from the other ear. But we don't know that. And we don't know about what causes the pain in the ear either. That's another one questionable question that we haven't been able to answer.
Are there any other options for recruitment?
Not that I know of.
Any other questions?
Yes, I would like to know, is there a way to get a consultation with Dr. Silverstein?
Yes. Yes, it's very easy. You can, we do telemedicine all the time. And what we like to see is a hearing test and an LDL test done by your audiologist. And if you can get a CT of the temporal bones, that's fine. If not, we'll order it. And then what happens is you call and make an appointment, and we do it by video.
I'm putting the phone number in the chat right now to make an appointment.
Right.
Thank you very much. I've talked to one other doctor in the group, and I would like Dr. Silverstein to please review my case.
Sure. So let me explain how this works now. So the surgery is actually done by Dr. Nyack, and I'm at the operating room supervising and coaching this surgery to make sure it's done right. And that's how we've been doing it for the last couple of years.
Okay, yes, thank you. I'm the one that can feel some vibration, but
Right.
I don't like the drums or the lower leaf blower has to be close to me. And
I think it would work. I think it may work.
wonderful. Okay. Yeah. I'm getting that temporal scan to rule out some other inner ear issues.
Right.
But I'll have another consult with him then. Thank you, sir.
We've done 80 cases now in about 100 years.
The next question is tinnitus louder after the surgery.
Some patients have had, a few patients have had worse tinnitus after the surgery. But that's been pretty rare. Most patients have, like I said, they're either the same as they were before surgery or that it helps them.
I don't think there's any other questions.
Okay, great. Okay, if you want to make an appointment or talk more about it, it's very easy to call and make an appointment for a web Zoom type of consultation. And
I just put the phone number in the chat for everyone.
Okay, great. Okay, thank you.
All right, thank you.